Hello, this is our lecture number 30 now. We're going to study the area of motivation and in particular a lot of the interesting work that's been done on the study of hunger, our eating behavior. What are the physiological controls? What are the biological controls of this obviously very important behavior? We're going to do this by accessing the study of hunger by taking a look at an eating disorder called anorexia nervosa. And I think that by understanding that eating disorder is going to help you to understand some of the work that's been done on the biological control of our eating behavior. So let's begin this analysis by acknowledging the fact that certainly there are many different factors that contribute to our eating behavior. Certainly, we'll be exploring, a little bit some of the environmental factors, situational factors, social factors, and so on. But this is a complex motivated behavior, one in which, I like to take a look at a little bit of history here to help us to understand, the complicated nature of the study of this disorder. So whenever we talk about the area of motivation, we're talking about hunger, we're talking about thirst, we're talking about things like sexual behavior and aggressive behavior and maternal behavior. We use what is called the SOR model. And S refers to stimulus, O refers to organism, R refers to response. So in the case of these, basic motivational processes like hunger, we experience a need. There's some kind of a deficiency that we experience. In the case of hunger, we need food in order to survive. And then, we behave in a certain way. We're driven to behave in a certain way in order to try to obtain food. And then certainly achieving that goal of actually obtaining food. This is the incentive that really is prompting our behavior. So the SOR model essentially is saying that what goes on within the organism is speculative, and we do it on the basis of what we see an organism do in response to a particular stimulus situation in the environment. So the SOR model then is one that has been used very effectively in order to try to understand what is going on inside that black box, what is going on inside the brain. We can make important conclusions. We can speculate about what is going on within the organism based upon how an organism responds to various stimuli that it is exposed to. So indeed, this is if you go back in the history of the study of motivation, this model is one that has been used for a very long period of time. An important study that was done some years ago, I think, is noteworthy. This was done back in the 1950s, early 1960s by a Canadian psychologist by the name of James Olds. And this work is important for a number of different reasons. I mean, it helps us to understand what the underlying biological factors are that are involved in motivation. This is work that you should have heard about in an introductory psychology class, but in case you didn't, let me go over it a little bit. James Olds takes a rat and implants the rat in a brain area called the medial forebrain bundle, which he implants an electrode there. And the animal is placed in a box like what you see here. This is called the Skinner box. And the animal can learn to press this bar that you see right here. And when the animal presses the bar, it activates this stimulator here, which provides electrical current to the animal's brain. So the animals will easily learn how to press a bar in order to obtain that stimulation. And indeed, it is something that they find to be very rewarding. They will do it repeatedly in order to obtain this very pleasurable stimulation. And what we know about this work, what James Olds and others learned, was that the part of the brain that seems to be involved with this is what's called the medial forebrain bundle, of which the nucleus accumbens is a very important part. And dopamine, the neurotransmitter dopamine, appears to be playing a very important role in this. So this work, this older work, really set the was the forerunner of a lot of other work that was done in the area of the study of motivation, because Olds now apparently is able to map out what parts of the brain are involved in pleasure, in how we experience pleasure, which is incredibly important when you talk about motivation. Motivational systems, there's two important neurotransmitter systems that apparently are involved. And you see one that's in the blue here. These are dopamine system here. Here's our dopamine system that you see right here in the blue. This is the frontal cortical area. Again, this is parts of the old brain that you see here. Again, these are dopamine pathways, and again, we're talking about the nucleus accumbens, and we're talking about the medial forebrain bundle, substantia nigra, the striatum. These are all parts of the brain that are apparently involved in reward. They're involved in how we experience pleasure. They're involved in compulsive behaviors. So involved in a lot of different behaviors that are associated with subjective pleasure. The serotonin system, on the other hand, seems to be involved in mood. It's involved in memory processing. It's involved in sleep. It's involved in various cognitive behaviors. And if you take a look at this system, which is here in the red, okay, this is the serotonin system that we see here, which is impacting also many different parts of the cortex, not just the frontal cortex of the brain. The raphe nucleus in particular is a very important part of that pathway. So this is something that scientists have known for a while now, that these two systems seem to be very much involved in various motivated behaviors. Before we get into an eating disorder, I want to talk about this technique that we'll be referring to not only in this particular area of the study of motivation, but in other areas as well. This is a technique, it's called microdialysis, in which we can sample the brain in terms of neurotransmitters that are being released. How much of those neurotransmitters are being released, that is, their levels, and something that we call the turnover rates. That's how much of the neurotransmitter is actually being produced. And it involves implanting this a device that you see here, in which we can sample the neurotransmitters in the brain. And it's really designed to mimic a blood capillary system. The principle of permeable membrane. We can draw off these substances and periodically sample how much neurotransmitter is actually in circulation by drawing off these samples periodically, that is, every few minutes, for example, and we can get an assessment of um, what the levels actually look like of this neurotransmitter. Now, this can be done in a freely moving animal, and this is, really important work. This technique is something that has been around for a little while now, but it is one that has been found by neuroscientists to be very helpful in terms of understanding exactly what is happening in the brain, almost moment by moment, in terms of neurotransmitter release. There are some major questions in this area, and again, I'm going to start out by talking about eating disorders, and one of those disorders is anorexia nervosa. Why is it considered to be the deadliest of all behavior disorders, this refusal to want to eat? And again, what are the theories that behavioral neuroscientists and psychologists have advanced to try to understand how it actually comes about, its etiology, and what kind of treatments do we have to help those that are suffering from this disorder? I don't often get into some of the applied end of things, but I think it's important in the context of this particular eating disorder. I think it'll help you to understand the kind of research that goes on in this area. This is something that we're bombarded with in our culture. This whole idea of thin is in. And I think that these images are something that we see beginning at a very early age in life. Again, more pictures of this whole idea of thin being something that is really valued in many different cultures. Indeed, when we take a look at movies, when we take a look at video games, invariably the images that you see are of women who are very slim, who are very thin. Even in children's videos, as you see here, this is what young children are looking at, and in terms of modeling. Without question, thin is in many different cultures. Many of you may be familiar with the movie from a few years ago, Black Swan. Natalie Portman played a woman who was a world-class ballerina, and essentially it was her struggle in terms of maintaining a very low body weight and the impact that it had upon her in terms of her health and in terms of her mental health. So this is a very pervasive part of many different cultures, this whole idea of thin being so important and so valued. The historical origins of this disorder, if you take a look at that picture that you see on the right, this was one of the first recorded cases of anorexia nervosa. This was back in 1866. This was before treatment. This is after treatment. This individual simply labeled as Miss A. So it goes back that far, and this was from the published papers of Sir William Gull, who was a physician during this period of time. Anorexia, here's one of my all-time favorite studies, and this is going to illustrate, I think, an important part of trying to understand this disorder. I'm not sure how many of you may have been to the Fiji Islands. It's a beautiful, absolutely beautiful islands in the Pacific. And prior to 1990, the incidence of anorexia nervosa in this island, Fiji Islands, was near zero. But then something very interesting happened. American television programming, things like 90210, Melrose Place, became available, and indeed the images that you see in those television programs are of women who are very thin. Once that programming became available by satellite, the incidence of anorexia nervosa just shot up in a very dramatic fashion. This is very interesting, and I think that what it does is that it illustrates to us that these very important social and environmental factors, cultural factors, can play a very big role in terms of how we go about regulating our eating behavior. So I don't want to minimize those things. We just simply acknowledge them. We want to understand the underlying biology of disorders like this, but let's acknowledge the role that culture and the environment play. Certainly, there have been some cases of anorexia nervosa that have been pivotal in terms of this disorder coming out of the closet. Here's one of them. This is the singer-songwriter Karen Carpenter, whose work, though you may not be familiar with it, her work, she's considered to be one of the greatest singer-songwriters ever. And she passed away at the age of 32 from heart failure. Here she is during her peak of popularity. And she lost close to 50 pounds over a 2-year period of time, passing away in 1983. Here she is in 1977. She weighed only 83 pounds. And indeed, she essentially passed away from heart failure. And indeed, at a very, very early age, she wrote so many wonderful songs and performed those songs. She was probably one of the most popular singer-songwriters ever in our history. So this was a pivotal point. This is when anorexia nervosa finally came out of the closet, and doctors now started getting more interested in studying it. Society became more interested in knowing more about it. Indeed, if we take a look at some of these images like what you see here, this captures, I think, more than anything, what this disorder looks like. It's the unwillingness to eat, what is needed, and there is a genetic predisposition that is involved. If you have a sibling with anorexia, you are 10 to 20 times more likely to become anorexic. The concordance rates in identical twins are relatively high, somewhere in the neighborhood of about 50 to 80%. So that really argues for there being a strong genetic predisposition. It is the fear of becoming fat. Okay, it's not being disinterested in food. It's the fear of becoming fat. There are biochemical abnormalities that occur. We're going to be talking about some of these in terms of serotonin and in terms of dopamine, but that's probably not the cause of the disorder itself. It's rather the result of the weight loss. There are clearly psychological factors that are involved in the etiology of this eating disorder. Here's the single most important and most alarming feature of this disorder. It is the highest mortality rate of all psychiatric disorders, 6%. That is incredibly high, right? So again, of any psychiatric disorder, this has the highest mortality rate. So in other words, for every 100 people that are diagnosed with this disorder, 6 of them will die as a consequence of it. That's incredibly alarming. So let's try to make this distinction between dieting and anorexia, okay? Because dieting is very different from anorexia. And dieting, it's healthy. You want to control your weight. Your self-esteem is not wrapped up in it. It's more than just your weight and your body image. There are other things that drive who you are and what you value. You view weight loss as a way to improve your health, as a way to improve your appearance. Your goal is to lose weight and to lose it in a healthy way. Contrast this now with anorexia. And anorexia, it's really an attempt to control your life and to control your emotions. Your self-esteem really is just so intertwined, with your with your weight and how thin you are. And again, you see this as a way of trying to achieve happiness in your life. And being thin is all that matters. Your health is not a concern. So again, very, very different from what we see in terms of dieting. Let's not confuse the. Here again, some more essential facts about anorexia nervosa. It afflicts women 15 to 24 years of age, much more so than men by an order of about 10 to 1. It's the intense fear of eating. Women who are anorexic have this distortion, okay, of their body image. They're pursuing thinness all the time. It's unrelenting. Many of them are exercise obsessed. This is something that can cause fatal damage to the heart muscle. This is what happened with that very famous singer-songwriter, Karen Carpenter. We have people who are anorexic develop these perfectionist personalities. And again, and I can't emphasize this enough, this mortality rate, 6%, extremely high. Right? So there are a number of theories of anorexia. One is called the positive set point theory, and essentially it's saying that biological changes are associated with this disorder. Neurotransmitters such as serotonin, for example. We'll specifically get into that serotonin theory in just a moment. There's also what's called the incentive theory, which says that ordinarily food is a positive incentive. We like to eat, and we derive a lot of pleasure from it. The incentive theory simply is saying that in anorexic individuals, eating food is no longer pleasurable. It's not something that we desire any longer. It is not something that we find to be fulfilling, that we find to produce subjective pleasure. So one researcher by the name of Woods has really brought this theory to a whole nother level in terms of what we call the aversive physiological effects of meals. And what Woods says is that ordinarily the pleasant aspects and the negative aversive aspects of food are balanced. So at the start of a meal, what we're looking at in terms of food is this pleasant, there's some aversive effects, but it's totally in balance with one another. But that homeostasis is disrupted in anorexic individuals by a sudden infusion of calories. So the aversive effects of eating are much greater in people who have been eating very little. And again, those aversive effects, those negative effects, build up to a level where an individual simply avoids food and doesn't want to eat food at all. So meals are extremely aversive for these individuals, especially individuals who've gone through an extensive period of food deprivation. Take a look at those images that you see there of those concentration camp prisoners that were freed towards the end of World War II. One of the mistakes that was made was allowing these individuals, once they were freed, to engage in as much eating as possible. And indeed, what happened with many of them is that they couldn't tolerate that sudden infusion of calories. And indeed, this was probably one of the worst things that could be done with an individual who had been food deprived for such an extensive period of time. So why do severe anorexics not experience a large increase in the positive incentive value of eating? I think that that's an incredibly important question, and one that I think a little piece of research here with animals will help us to understand it. If you were to take a rat and allow that rat to drink from this water bottle that has saccharin in it, so it's a sweet water, which rats simply love. And then you were to make this animal ill, And this can be done by exposing them to a little X-ray radiation, which would make them nauseous and make them sick maybe for a couple-hour period of time. And then place them in a situation where they can drink either the sweetened water or regular tap water that's not sweetened. What they will do is they will avoid the sweetened water, and instead they will lick from this tube that you see here. This is something that's called conditioned taste aversion. And what we know is that in this situation, in this case with rats, they essentially learn to associate that sweetened water with illness. So now in the future, they avoid it. Well, understanding that very simple principle is very important for understanding the etiology of anorexia. You know, forcing meals on an anorexic patient may be the single worst thing that you can do, simply because you're going to have a development of conditioned taste aversions, and that's going to reduce the motivation to eat. So indeed, you know, that positive incentive value of eating really is almost gone, is gone. Instead, what you have are these conditioned taste aversions that are really reducing the motivation to want to eat. So the implications of this theory for treatment then is, a patient should not be encouraged to eat larger normal meals. They should have small meals, small amounts, given food intermittently throughout the day, and again, some of this involves infusing food by nasogastric tubes, for example, but very, very small amounts of food, and again, intermittently throughout the day. No large meals, no normal meals for a recovering anorexic individual. Another disorder that's associated with this is one that we call bulimia nervosa. This too is an eating disorder in which a person is alternating between this dieting, which is extreme, and binges of overeating, and you get forced vomiting as a consequence of this disorder. It seems to be related in part to what is happening to a gut hormone, which is called CCK. That hormone ordinarily, when it's released, induces satiety, meaning that the person's no longer hungry. So you get an increased release of CCK and ghrelin, alterations that occur in a number of different neurotransmitters. Importantly, this whole effect, that is of the CCK, it may be the result and not the cause of the disorder itself. There are other deep-seated historical factors, cultural factors that are involved with the etiology. One of the other things that we know is that reinforcement areas of the brain are also implicated. Remember, we talked about that study that was done by James McGill some years ago, in which he looked specifically at the parts of the brain that were involved in mediating pleasure. When we take a look at the impact of anorexia, it impacts just about everything in a person's body, whether we're talking about what's happening in the brain or what happens in terms of your heart, your blood, kidneys, body fluids, intestines, secretion of hormones, your skin, your bones. It's impacting just about everything in an individual. So the major hypothesis in this area to try to help us to understand anorexia is called the serotonin hypothesis. Serotonin is a neurotransmitter that's released in the brain. Seems to be involved in anxiety, seems to be involved in mood changes. I think we talked a little bit about this earlier. The theory is this: anorexics have high serotonin activity. That high serotonin now is stimulating a decline in terms of appetite. And it becomes a vicious cycle. The more 5-HT receptors, serotonin receptors that are being produced, then there's more and more serotonin that's being released. So indeed, this is probably one of the major theories of anorexia, but it's really nothing about what the initial cause of anorexia is. It's more about what is happening, after these various psychological, cultural kinds of factors have their impact, that these brain changes are associated with the continuation of this disorder. So the serotonin hypothesis, again, here's a visual for you. Serotonin increases in the brain as the anorexic individual attempts to starve themselves. Then serotonin receptors that you see here are increasing in the brain. That's to accommodate all the additional serotonin that's being secreted in the brain. Our two systems, neurotransmitter systems, dopamine and serotonin. Once again, just to review this, dopamine is involved in reward and the experience of pleasure and euphoria. Serotonin, on the other hand, principally involved in mood and memory. It's involved in sleep as well. But these are, the two very important pathways that are involved, seem to be involved now in terms of impacting anorexia nervosa. Anorexics suffer from what is called anhedonia. That is, they don't experience pleasure in the normal way. And there's a lot of biological evidence and behavioral evidence. One of the things that we know is that there's an absence of normal brain dopamine responses. For example, if you were to show a picture of some food, let's say, to an anorexic individual, they would show little change at all in terms of dopamine. Show that same picture to a normal individual, and they would probably show some dopamine changes in the brain. So it's the absence of normal responses to not only to pictures, but the actual presence of food and to other people. It's not something that they derive pleasure from any longer. Things that at one time really drove their feelings of pleasure and satisfaction and joy, they don't do it anymore. And one of the reasons, biological reasons for this, is the fact that the brain dopamine system simply isn't responding any longer. Anorexic individuals, we talked a little bit about therapy. Here's an anorexic individual here. This was after over a year of very extensive therapy. I think it's important to talk about this a little bit so that we understand it. Major therapies for anorexia, certainly psychotherapy, family therapy. There's certain medications that we will talk about that can be used principally in the treatment of depression. There are residential facilities, there's hospitalization that can actually occur, self-help groups. The bottom line is that you really may need all of these things in order to adequately, you may need a whole clinical team with different specialties in order to successfully treat individuals that are suffering from this disorder. So there's 3 essential steps for treating anorexia. Certainly one of the first things is that a physician would have to keep in mind is that you want to get them back to a healthy weight. Starting to eat more food, certainly, but small meals. Once again, not this sudden infusion of calories. But you really have to work at getting the patient to think differently about themselves and to think differently about food. So one of the treatment tactics that's certainly very popular in treating anorexia is psychotherapy, namely cognitive behavior therapy, CBT, is really considered to be the best treatment. You have to get at the underlying emotional problems that this individual, this patient, is trying to deal with in their life. This is what has caused the disorder. So again, it's these negative kind of patterns of thinking these attitudes and belief that are involved that have to be changed. So you have to dispute those things in cognitive behavior therapy. So you want to get the patient to understand their problems and to identify and to change this irrational kind of thinking that they constantly are engaged in. Again, psychotherapy is certainly very effective in treating anorexia. I mentioned earlier that all treatment options are available, many specialties. To adequately treat this, psychologists, medical doctors, nutritionists, people that are specialized in meditation and relaxation, fitness experts, body image experts. This team approach becomes incredibly important for successfully treating individuals that are suffering from this disorder. Antidepressant drugs certainly can be helpful, but you would not put an anorexic, once they're diagnosed, on an antidepressant drug immediately. That's probably going to do nothing. What you have to do is you have to obviously get them involved in a complete physical exam. Then, after that, and after having been involved in some psychotherapy, then it's typical to put a patient on an antidepressant drug. But just to treat it initially, without having gone through an extensive physical examination, is not something that's going to be productive. There's also oftentimes treatment of women with estrogen therapy in order to counteract the osteoporosis that ordinarily is another very disruptive characteristic for these individuals. Family therapy, certainly the context of a lot of these problems that you see in young women is that there's a dysfunctional family and their eating behavior and how that eating behavior may be impacting them in terms of the etiology of this disorder. Family therapy sometimes is conducted with the entire family, sometimes without. Parents oftentimes are also asked to engage in something that's called the Maudsley method, in which they assume a major responsibility for helping with feeding and staying on top of the eating behavior of their child. Hospitalization for anorexia, this is something, there are benchmarks for this. If an individual is severely ill, 15% below their normal body weight, an anorexic patient is immediately brought into the hospital. You get lower than that in terms of losing so much body weight, then you're very much at risk. So again, hospitalization is crucial at that time. When a person is hospitalized, they're encouraged to eat regular meals, use liquid supplements. That's also possible. Nasogastric tubes, also another possibility to make sure that these individuals are getting adequate calories and not move to outpatient therapy until they're stabilized medically. So again, getting a person back up to a healthy body weight becomes a key factor in the treatment of this disorder. Here's a new and interesting therapy that I talked about a little bit when we were looking at methods, but it was one that's been advanced by this British physician, psychiatrist, Jessica McClellan. And it involves this repetitive transcranial magnetic stimulation, in which you're passing over the dorsal frontal cortex these magnets. You're holding that coil fairly close to the skull, and again, it's passing electrical current into that part of the brain. It is impactful. in terms of reducing the urge to restrict food. It is impactful in terms of these feelings of being overweight that these individuals have and the feelings of being full. They no longer feel that after having experienced this repetitive transcranial magnetic stimulation. It improves their cognitive control. Again, the individuals become very impulsive that are anorexics. And again, control over this becomes important. How is it doing this? Well, neurobiological changes, certainly in terms of dopamine and serotonin, changes in terms of what's happening to action potentials in those areas that are being stimulated. We don't know precisely how it works. And again, this is something that is still in clinical trials, and we'll certainly know more about it as science advances and we find out who it's effective for and how long lasting is that therapy. So a few conclusions at this particular point before we get into some of the basic research that's been done on the biology of hunger. Anorexia, without question, is the most fatal of all behavior disorders. Culture is exerting an incredibly important role. Genes and the dopamine system and serotonin system may be implicated. Again, the more recent research is indicating this phenomenon called Anhedonia, which is mediated by the dopamine system. Patients simply don't experience pleasure in the same way any longer. So serotonin system certainly involved, but increasingly we think that dopamine also is involved. Treatments for anorexia often require this full range of specialties, different specialties in order for recovery. So it's a very perplexing, complicated disorder, this eating disorder, but I think understanding a little bit about it kind of sets the stage, I think, for more fully understanding the biology of eating behavior. And that'll be the topic for our next lecture.